So it is my honor to introduce this next speaker. She is a true leader in the CCHS clinical and research community. She is absolutely adored by her CCHS patients, and I am so very lucky to call her friend, Dr. Maida Chen. Dr. Chen is the director of the Pediatric Sleep Center at Seattle Children's Hospital. She is also an associate professor in the Department of Pediatrics at the University of Washington School of Medicine. She obtained her medical degree at Northwestern University, did her residency in pediatrics with Dr. Wiesmeyer at Rush Presbyterian St. Luke's Medical Center, and then completed a pediatric pulmonary fellowship with a special focus on respiratory control and sleep medicine with Dr. Keynes at Children's Hospital, Los Angeles. Her clinical practice centers on sleep disorders in infants, children, and adolescents. Her research focuses on respiratory control disorders and sleep disordered breathing in special needs populations like CCHS. She is a member of the American Academy of Pediatrics, American Thoracic Society, American Academy of Sleep Medicine, and Sleep Research Society. Dr. Chen also serves as a board member on the CCHS Network Research Advisory Board. This is a panel that reviews CCHS research grant applications for funding. In this presentation, Dr. Chen will be talking about ventilation options available to CCHS patients. Welcome, Dr. Chen.
Hello, everybody. My name is Maida Chen, and I am a professor of pediatrics at the University of Washington School of Medicine and Seattle Children's Hospital. And I am here today to talk about ventilatory options in individuals with CCHS. As you can see in this picture here from one of my most favorite movies, The Princess Bride, I'm hoping that we can do a little bit better than what they have to offer here, but there's lots of options and there's a lot of nuance when it comes to ventilatory support in CCHS. So let's get going. So today we're going to talk about an overview of ventilatory management in CCHS. We'll discuss common modalities of ventilatory support, and we'll review the transition between modalities, particularly going from a positive pressure ventilator with tracheostomy to other options that are less invasive. However, before we begin, I do want to make a small note that a lot of what I'm going to present is based on current thinking in CCHS right now. And that right now, in terms of that paradigm, is that all children with CCHS need lifelong ventilatory support. And right now, that is still definitely what I believe. But I will say there is a lot that we are learning about children who have different FOX2B mutations that may not need the same levels of support that we once believed all children with CCHS to need. So with that in mind, moving on. So with ventilatory management, we know that children with CCHS and adults with CCHS, at this point, we believe to have lifelong dependence on ventilatory support while asleep, with anywhere from 20 to 30% needing while awake, and a lot more children who need it intermittently during wake hours, like with illnesses and procedures and things like that. My practice is such that, and CCHS guidelines are such that titration of support at least annually should occur, ideally at a center with CCHS expertise, or frequently when they are in early childhood. We have titration of support can occur both clinically as well as in a sleep laboratory, to some extent, ideally both. We titrate support such that we have goal saturations of greater than 95% with the lowest possible amount of supplemental oxygen and on the lowest kind of settings. Generally, this occurs with an FiO2 of 40%, which translates roughly into 2 to 3 liters through a ventilator, so less than that. And most children with CCHS are able to be ventilated while just on room air. Our goal CO2 levels are between 30 and 45 millimeters of mercury. There's a range there, and there's a difference in preferences according to providers. I tend to go towards the lower end of that, just so that kids, when they're off their ventilators during the day, have a little bit more reserve. I also really believe in careful evaluation of breathing off support, both awake and asleep at certain intervals of time. Obviously, this needs to be done in a very carefully monitored and controlled setting, but I do think it provides really important information at various points in time, as well as longitudinally over a child's lifetime in terms of what their breathing looks like when off support, because despite everybody's best efforts, it will likely happen at some point in time. Objective monitoring is also critical in the ventilatory management of those with CCHS. And there's a wide variety of practice in real life amongst families who have individuals with CCHS in terms of what they actually do, what their preferences are, what their comfort levels are. These can include things like oximetry during sleep, which is currently a fairly standard recommendation, spot check capnography, if not ongoing capnography, which is end-tidal CO2 or transcutaneous CO2 monitoring. End-tidal CO2 machines are something that are difficult to get oftentimes, both from an insurance authorization perspective as well as the actual machines. Certainly doesn't mean that we don't try. The machines we like to use in those with CCHS should really have disconnect alarms so that you know when they are not working at the very least. And then another fairly standard recommendation, although one that is very difficult to adhere to for a variety of reasons, is to have overnight nursing, but particularly in the younger infant and childhood stages. In terms of general concepts of ventilatory modalities, it's really important to know that it is not a one-size-fits-all model. Resources and support vary immensely, both geographically as well as by individual family. And really, individuals with CCHS and their families, you're their own best advocates. You're your own best advocates, and your own best experts in that sense. And so if you have a child with CCHS and you come into an emergency room, most likely you are going to be the one in the room who has the most knowledge of CCHS. So it's really important that whatever is suggested and whatever is implemented for vent support in your home are ones that you feel comfortable with and that work best for your family's life. Moving on, to understand different ventilatory options, we need to review the mechanics of a breath, which we'll go through in the next few slides. And I know Tom Keynes is giving a lecture on sort of breathing in general. This is really about the mechanical breath and how a ventilatory assisted device can help with that. So in terms of the act of spontaneous breathing, we have the brain and then its communications via nerves within the spinal cord to really the chest and airways. And let's just go through this. So we have our major windpipe, which is the trachea, ribs and intercostal muscles. We are looking at the side of the chest here. Lung, and then diaphragm, which is a domed muscle. We have the phrenic nerve, which obviously then directly connected to the nerves within the spinal cord. And the phrenic nerve is the nerve that gives communications to the diaphragm, and many of its accessories also give communications to the ribs and intercostal muscles. When that phrenic nerve gives a stimulus to the diaphragm, that diaphragm then moves up and down and it goes from a dome shape to a flattened shape. And that is the act of respiration. At rest, so at the end of an exhalation, the end of a breath, your diaphragm at rest passively is floated up in this domed-like position. With active inspiration, the diaphragm contracts. It flattens and goes down. When it flattens and goes down, the ribs and intercostal muscles, which are the muscles between your ribs, also expand. That increase in volume in your lungs then creates a negative pressure where air is sucked in from the outside. So a natural breath is one where air is being sucked in. A very exaggerated natural breath is a hiccup. So think of when you hiccup, how quickly air comes in. That's obviously very exaggerated, but that is the closest thing that we have for comparison in terms of a natural breath. Air is getting sucked in. So negative pressure ventilation is when air does get sucked in. We can do that two ways. One is by contracting the diaphragm by phrenic nerve stimulation. So we directly communicate with the phrenic nerve. We will talk a lot more about this. That then sends a signal to the diaphragm to flatten out. And then the diaphragm contracts and brings in air. Another way we can do that is if we physically pull the chest wall out. So we pull the ribs and intercostals out. That also causes the ribs to expand, the diaphragm to flatten. Again, air is sucked in. So that is negative pressure ventilation. This is in contrast with positive pressure ventilation. So in positive pressure ventilation, air gets pushed in. We connect that airway either by a face mask or by tracheostomy to a machine that then forces a certain amount of air into the lungs, and that then is the thing that results in a breath and gas exchange in that sense. So to review, our ventilatory modalities are positive pressure ventilation by trach or by mask, our negative pressure ventilation by cuirass, which we will talk about and is not all that common, and by diaphragmatic pacing via phrenic nerve stimulators. There's also, again, I want to raise the possibility, and while this is not convention and it's not paradigm thinking yet, there is the possibility, and certainly there are individuals with FOX2B mutations out there who are not on any kind of ventilatory support or just on oxygen. This is very controversial, and we don't know that much about it yet. But lots of individuals like this some of them appear to be completely healthy and functioning. And so we have a lot to learn about some of the more rare FOX2B mutations, and particularly the non-polyalanine ones. Again, controversial and not necessarily accepted as standard practice, but I just want to put it out there that I do think the world of CCHS and ventilatory modalities is potentially changing. So our menu of options is really dependent on how much ventilatory support a child needs. And this primarily is meant in terms of duration of hours per day. So if you have a child or you are an individual with CCHS who requires 24-hour support, or you have frequent need for daytime support, whether it be due to illnesses or just individual variation, options include positive pressure by trach, 24 hours a day, positive pressure by trach at nighttime with diaphragmatic pacing during the day, positive pressure by mask, so BiPAP, it's usually referred to at night with diaphragmatic pacing during the day, or negative pressure ventilation via cuirass at night with diaphragmatic pacing during the day. Nighttime only children, or children who require it mostly just during sleep with only very occasional need or rare need during the daytime, options include positive pressure by mask or BiPAP, diaphragmatic pacing with or without a tracheostomy, or negative pressure ventilation with or without a tracheostomy. For positive pressure ventilation, you're going to see a lot of terms that may or may not directly mean anything to families or individuals who are on these settings. But the biggest thing to understand with positive pressure ventilation is that it is programmed to deliver either a certain pressure or a certain volume to your airway. And in those with CCHS, that ventilator needs to have a built-in rate set with it so that it is doing this for you at intervals which constitute a respiratory rate. Those modalities can include something we call SIMV, which is synchronized intermittent mandatory ventilation, or assist control. Either of those two can come in either a pressure control mode or a volume control mode. All that means is what the machine is programmed to deliver, either pressure or volume. We have something called bilevel positive airway pressure. Again, this can be via tracheostomy or mask, and this can come in a spontaneous timed mode or a timed mode. For those on BiPAP, it should not be in just spontaneous mode in those with CCHS. And then we have newer, more sophisticated, somewhat hybrid settings, which include an example of would be AVAPs, or average volume assured pressure support. Many with CCHS don't require hugely sophisticated ventilator settings because they have normal lungs and are fairly easy to ventilate for the most part. But very sophisticated hybrid models do exist now and can be helpful in those who have both lung and airways disease in addition to their CCHS. So let's go through all of these, and I'm going to put this in benefits and challenges columns. These are certainly based on practice and what a lot of experts within CCHS believe, but certainly not written in stone in anywhere. And again, this varies quite a bit by individual and by family. So the benefits of trach and vent during infancy and young childhood. Really, this is the standard recommendation because it is our way of giving the most assured ventilator delivery during a critical time of development and growth. Excuse me. Babies have really unreliable sleep and wake. Lots of sleep is involved. They don't tell you when they're about to fall asleep. And many of them are not quite ready to sprint completely when they are awake, which is why having a tracheostomy in place makes it easiest to afford to deliver that ventilatory support. Another aspect of it, another angle of it, is that in terms of the other options, babies are not well set up for other options. There's a lack of masks available in terms of mask BiPAP for babies. There are many more mid-face concerns in terms of early use of BiPAP mask in terms of restructuring that mid-face. Many babies are not able to trigger or synchronize with mask ventilation at a very small size. Conventional BiPAP machines, which I necessarily recommend in this age group, but sometimes that's all that's available, are not actually FDA approved in young children. Their chests are very compliant, meaning they're not quite rigid yet because the bones haven't formed very well. And their upper airway is very collapsible. So if you try something like diaphragmatic pacing or negative pressure ventilation, they oftentimes will have collapse of their upper airways. Other options, or I'm sorry, other benefits that come with trach and vent, and again, I say this as a benefit, although many families don't necessarily view it as a family, is that at least in the United States, this is the most likely scenario where private duty nursing will be both approved by insurance, but also actually implemented within the household. It does avoid intubation with illnesses and procedures, which are more likely to occur in that first year of life. And importantly to me is it frees up the face, which is critical for social development. Challenges include, obviously, there is huge, massive medicalization that occurs in somebody who requires tracheostomy and ventilator support. I feel like that should be number 1 through 100 because just giving it one bullet point certainly does not do it justice in terms of how very impactful and in many times negatively impactful it can be on a family. Due to the lack of home nursing in many areas and just the recovery time and the training that is needed for families, the initial hospitalization for tracheostomy placement, oftentimes in that neonatal age group, is lengthy. I mean, we're talking months at a time. It can delay phonation or vocalization because of the tracheostomy, although this does tend to recover. Kids, especially infants who have had a lot of medical procedures, can develop an oral aversion, particularly with suctioning. And just in general, having a tracheostomy and ventilator, it's very cumbersome. Despite the battery capability of most ventilators, you always need to have lots of equipment, like always, especially with an emergency tracheostomy and airway, bagging, potentially oxygen. There's a lot that goes into it. In older kids and youth and going into adolescence, tracheostomy affords, it continues to be the most assured form of ventilator delivery. And I will say particularly, it becomes pretty easy for families to connect that tracheostomy to a ventilator without a whole lot of child cooperation. Yes, a kid can definitely rip it off, but in the off chance that a child is sleepy or has already fallen asleep, which even though I know that's not supposed to happen, let's face it, it happens sometimes. It is easiest for families to connect without needing to wake the child up to put on a mask or put on antenna for pacers. You are more likely to maintain home and school nursing if, with a tracheostomy in place, which again can be a pro or a con. Still avoids intubation with illnesses and procedures. Most older kids with CCHS can phonate even without a passy-mirror valve or a cap in place because, again, they have healthy lungs and airways. Most can remain with small cuffless tubes at pretty low settings on the ventilator to avoid and minimize any trauma done to the airways or lungs. And most can eat and drink by mouth without difficulty, even with an indwelling trach. Challenges obviously include the ongoing obvious medical complexity, which sometimes is a good thing, sometimes is not a good thing. There is something that having a tracheostomy in place buys a certain amount of street cred when you walk into an emergency room. People will pay attention to somebody who has a tracheostomy and believe that somebody who looks otherwise typically developing does have a life-threatening illness. Whereas if a tracheostomy is not in place, that becomes a lot harder for those not familiar with CCHS to triage. Certainly, as our kids get older, the social stigma and related medical rebellion that comes with having medical complexity arises as a real issue. Anything with indwelling plastic or metal in your body is something that is a foreign body and raises a risk of frequent tracheitis or infections. Obviously, and a big thing for a lot of families is limited swimming when you have a tracheostomy in place, no matter how well you can plug it. And even if they are weaned off support while awake, meaning they are not connected to the ventilator most times when they are awake, you still need that emergency equipment for the tracheostomy when outside of the home. So we're all familiar, I think, with a lot of the ventilators that are out there. I will say every one of these ventilators, so this one, let me just see if I can do my laser pointer here. So this is the ResMed Astral. This is the Respironics Trilogy, many models of which have recently been recalled without a great backup plan. A filter in place does mitigate a lot of those issues. This is the newer version of the trilogy, which is called the Evo, not under recall. This is a newer ventilator called the Voxen, which does multiple functions. Again, these are not the only ventilators that are on the market, but certainly the ones that I use most commonly in my practice. In terms of tracheostomy tubes, these are cuffless tubes, but this is a Shiley, this is a Bovona. Again, they come in all sorts of sizes, shapes, flavors, cuffs, non-cuffs, different kinds of phalanges and things like that, but just the basics there. Moving on to mask ventilation. So the benefits of mask ventilation are that it, for the most part, allows for decannulation. This is something that is huge for a lot of families. With the newer machines, a lot of which are the machines that I just showed you, which traditionally have been hooked up to tracheostomies, but all of which are also capable of doing mask ventilation, they have the same alarms. And so whereas conventional BiPAP machines of the past had not very robust disconnect alarms and things like that, the newer machines still have a lot of the same level of alarms available with mask ventilation. Kids who are mask ventilated, generally it's easier to manage. Not always, but for instance, families don't need to carry around a go bag with like the extra tracheostomy equipment, suction, those kinds of things while out and about. And there is much more familiarity with things like BiPAP in the non-tertiary world. And that's largely been with the growing number of people who without CCHS are diagnosed with other sleep disordered breathing like obstructive sleep apnea who have similar CPAP and BiPAP machines. Challenges are that need to be considered though. So the main one that I worry about, or one of the main ones I worry about, is particularly the younger we start with mask ventilation, we will see mid-face protrusion. So BiPAP masks, which we will show pictures of in a minute, can reshape the bones and the structure of a kid's face. And the younger that child is and the longer amount of time they're on the BiPAP, they can have more and more facial changes with time, some of which actually require significant craniofacial surgeries when they are older in order to bring their midface and jaws back into realignment. BiPAP should not be used, or at least was not developed to be used in the home setting for round-the-clock use, certainly not more than for a few days at a time. People do it in the ICU these days in terms of short-term treatment for illness around the clock that is really in a monitored setting, but should not be done at home 24/7 for prolonged periods of time whatsoever. It is not as robust as ventilation via a tracheostomy, particularly in times of severe illnesses or with procedures. One challenge can be aerophagia. So that is that when you force air in via a mask, because it is going into a joint space with the esophagus, that kids can have a lot of bloating with it. It is not really considered portable. There is no battery, or at least a conventional battery that comes with BiPAP. There's less nursing support that tends to come with it. Mask options can limit what wearing either eyeglasses or even obstruct vision. It is certainly obstructive and obtrusive socially. It requires manual effort by the patient and usually during young childhood by the parent to use nightly. So instead of just a kind of a one-step connection, it is something where you really need to make sure that the fit is correct, and that is very user dependent, even for adults. So these are some typical BiPAP machines that are out there. This is the Respironics Dream Station, which is under recall. Most models of it are. And then here we have the ResMed Air Curve, which is one of the more common ones. Again, there are many out there. Masks also come in a huge number of variety, flavors, sizes, shapes. Here we have some traditional nasal masks. This is the traditional triangular mask that has been most associated with mid-face protrusion. This is our giraffe wisp mask, which you can see doesn't have a forehead piece and a little less obtrusive visually. There's a newer one called the Dream Wear mask that goes under the nose, is a little bit more similar to nasal pillows. Here we have traditional full face masks, which again are triangular and go over the nose and mouth. This is the Nani. This is the Dreamwear full face mask. No, excuse me. Oh yeah, this is the Dreamwear full face mask. And then this is the full face mask Quattro. Here we have different kinds of full face masks. This is called a Fit Life that goes around the whole face. And although it looks huge, it is actually least obtrusive from a visual standpoint. And then here we have something called the Amara Full Face View, which is, and this is another similar one where it is a hybrid where the nasal part, instead of going over the bridge of the nose, fits underneath the nose like pillows. And then you have the face, the mouthpiece as well. Full face masks tend to be the ones that we recommend for children with CCHS, just so that the air we can make sure from the device is going directly all into their airways, as opposed to a nasal mask, which where you can see if the mouth is open, the air can go straight out their mouth in what we call an oral leak. So the cuirass, negative pressure ventilation, moving into that. This is again where we literally pull on the chest in order to expand the ribs and intercostal muscles, flatten the diaphragm, bring air in this way. The original negative pressure ventilator was the iron lung, which was used with polio. Newer ones have been developed for the ICU setting. This is obviously not something that can be used at home. With the COVID pandemic, this is the one that is used in the home setting. It is by a company called Hayak, and you can see it is essentially a clear plastic shell. I call it a turtle shell almost, which fits very snugly, needs to have a good seal onto a child's chest, and that then pulls the chest out with certain breaths. The benefits of this is that for the most part, it allows for decannulation, not always, but it can, and that there's really nothing on the face. Whenever you have negative pressure ventilation, you can have upper airway collapsibility that you cannot predict ahead of time. You just won't know until it's tried. The cuirass is not very portable at all. There is limited familiarity or use with it, which matters if you have a child in particular that requires frequent hospitalizations or elevated care outside of the home. And it can't be used if you have any chest wall deformities or if there is any sort of asymmetry to the chest, so any kids with scoliosis. Phrenic nerve stimulators and diaphragmatic pacing. This is the system that is FDA approved. It is by a company called Avery Biomedical, and this is the Spirit transmitter. Here we have the actual device that is generating the electric pulses, which is called the transmitter. You have antennas, which are these circular things connected by wires. This is not a wireless system. Those wires then connect to an antenna, which is placed over a receiver, which is implanted below the skin, and then electrodes, which are implanted internally on the phrenic nerve. Let's walk through this. But before we do, I just want to clarify that the diaphragmatic pacing I am talking about is not intramuscular diaphragmatic pacers. Namely, it is not the Synapse biomedical system. This system is one where it is intramuscular electrodes that go right onto the diaphragm that have little wires sticking out of their bodies, as you can see here, that are then hooked into the transmitter. This is something that is really meant for people who have ALS or quadriplegia, who have less sensation of their diaphragm, and is not really ideal in CCHS. So back to the Avery system. The benefits with diaphragmatic pacing are that for some, it allows for decannulation, but for a surprising amount, it does not. And that's something really important to keep in mind. The newer transmitter, the Spirit, has a disconnect alarm. It is very portable. It is non-intrusive. Challenges include this lack of ability to figure out if your upper airway is going to handle it without a tracheostomy or not. It does require surgery and general anesthesia for placement. You can only do it up to 16 hours a day. And you still, in my mind, need to have BiPAP available in the house in case those transmitters fail. You need to have a backup plan. They are not MRI compatible. So that is a major ding as we move toward using MRs for various diagnostic imaging. Any piece of these can get infected. The receivers will need replacement at least every 10 years. The transmitter itself is battery operated, which means that it's dependent on a human to change those batteries every so often. It requires manual application of the antenna and turning on the transmitter nightly. So this is not an automatic system either. There's minimal familiarity with diaphragmatic pacing outside tertiary centers, and it tends not to be as robust during severe illnesses. This is what I use for my eligibility pathway. It is not for everybody. It is not for people who have intrinsic lung disease or chest wall deformities, who need MRs in the future, like those who have VP shunts. You need to have a functional diaphragm and intact phrenic nerve, which is true in most children with CCHS. You need to have an upper airway that is as optimized as possible prior to pacer's placement. So we work with our ENT colleagues on that way. I try not to put them in anybody who has pulmonary hypertension, or if they do have a major cardiac arrhythmia, that they have their cardiac pacemakers implanted before we put in their phrenic nerve pacers, just from a surgical management standpoint. It just takes a lot of conversation beforehand. It is placed thoracoscopically with video assistance. I'm going to show a surgical picture upcoming, so just a fair warning. Here again, we have the side of our chest here, and you can see where the ports go in, where the robotic instruments go in, and the camera go in. This is the electrode, which is then placed on the phrenic nerve here. You can see that. Here is the drawing where this is the phrenic nerve, and the electrode, which is an alligator-looking clamp, goes right on top of that phrenic nerve, or right around it. The receiver is then, if this is our electrode here, the receiver is tunneled then into the abdomen usually, although this can be placed at various number of places, where the receiver is put right underneath the skin. This is what the receiver looks like. It's about the size of a quarter, and it feels like a little rubbery little thing underneath the skin. In most people, unless you are really thin, you can't actually see the receiver while you are upright in terms of protrusions outside the abdomen. Once the pacers are placed, it's important to know that while they are used intraoperatively just to ensure connectivity, they are not used in the immediate postoperative period to allow for healing. In the post-anesthesia unit or recovery, It really takes a lot of communication, even at a CCHS center with our anesthesia colleagues, to make sure that there is not just oxygen being given, that they're extubated to BiPAP or back to their trach and vent. Requires vigilant monitoring, including carbon dioxide levels. In the PICU or ICU, really need to go off daily objective metrics in that postoperative period. I usually recommend 24-hour ventilation for at least a few days, since these kids are at such high risk for atelectasis, post-op pneumonias. I ask that they stay in the PICU until they are off narcotic medications. Narcotics are a double-edged sword in those with CCHS, but really we want to make sure that their pain is controlled. But while they are on narcotics, they need higher levels of monitoring. And the incisions are fairly straightforward, no soaking, so no full submerged baths or swim, and open air to 7 days. After about anywhere from 4 to 8 weeks post-operative, we can then activate the pacers. That requires putting an antenna just over the skin, put in place with something like tape, or sometimes a sort of a wrap type garment. And it is connected to the transmitter. You can see here, the receiver is there. That's where the incision was. And so the antenna goes around there. This was the old transmitter, which I'm not going to spend any time on, but you can see that it was fairly archaic looking until pretty recently. This is the newer one, where you can see there are different voltages or amplitudes that are dialed in for each side. The higher the amplitude, the higher the voltage. The higher the voltage, the bigger the breath. There is a rate, and there are more bells and whistles on this one in terms of disconnect alarms and how to program it. Completing the initiation, it's very individualized. Some kids build up pacer time very quickly. Some really have some difficulty with it. Overnight nursing can be very helpful in these nighttime transitions, but it's important to know that I think you need really either a formal sleep study or very close monitoring, either in the hospital or in an ambulatory setting, to make sure that those pacers are set appropriately. So this is what the pacer looks like. Not sure how well the sound will project, but certainly you can see this child who is on the thinner side, what the paced breaths look like. It's gonna sound like an awful question. I'm gonna turn it up a little bit more. Are you okay with that? So you can see that those were fairly exaggerated breaths, and once we titrate them and fine tune them, the breath shouldn't look quite so dramatic. But this was the very first time that this child's pacers had been turned on, and you can see that he's in my lab setting where I have transcutaneous monitoring on him for CO2s and an oximeter on him to start his pacing experience. Okay, so I think we've reviewed now the various options that are out there for ventilatory support. Again, this is sort of that menu of options that we had before, and I think we reviewed most of these at this point in time. At some point, especially for the infant, for the child with CCHS who was diagnosed and trached in infancy, a change away from tracheostomy and positive pressure is oftentimes desired. Not always. And obviously there are some situations where this is not the best scenario for a family, but when families broach that, and I oftentimes will actually proactively broach that with families, even starting at a young age, just to get it, just to get everybody thinking about it and discussing what options look like later in life. But to me, it's very important to identify what the biggest drivers for this desired change are, because that definitely influences which way we want to go. If there is a desire and an absolute, no matter what, this tracheostomy needs to come out, for instance, and these are just examples here, I may recommend something like going to mask ventilation as opposed to diaphragmatic pacing as sort of a better guarantee of trying to get that tracheostomy out. If the big thing is portability and ease of travel, maybe having diaphragmatic pacers. If this is a child who has a ton of medical complexity and is frequently ill or frequently requiring procedures, A lot of times, unfortunately, children who have severe Hirschsprungs with this may fall into this category. Perhaps decannulation is not the best option right away. And there are lots of families, and just about every family, who has a certain set of hopes and desires with their child's journey with CCHS and support that is very individual. Like, we really don't like having nurses in the home, or we really like having nurses in the home, things like that. And so just open discussion starting at a young age, and just an awareness that this is not a quick conversation, nor is it a quick process. If you want your child decannulated, it's not going to happen overnight. There are lots of things that should go into it. And if somebody is saying, oh yeah, we'll just put them in the hospital, take out the trach and put them on something else, I would question that. There's a lot of thought that should go into that. So other considerations for transitioning away from trach and vent. Ventilatory needs. So again, if you have a child who is frequently needing 24/7 support, that is one set of recommendations. If it's nighttime only, that's another set. No upcoming surgeries, things like that. Age. So the upper airway, the more stable and a child's chest, rib cage, and upper airway are stable, that is something that oftentimes helps with successful decannulation. I know there is going to be an entire chat about decannulation and stomas and things like that upcoming, but just to mention here, getting to sort of early school age, 5, 6 years old, that upper airway becomes much more stable. Tonsils and adenoids tend to start shrinking after that point, or may need surgical removal. Midface and dental structures, that concern is ongoing, but certainly better at school age as opposed to infancy. You need to have some sort of mental ability to cooperate and understand with BiPAP if you are going to move to that away from a trach and vent, remembering that these children may not know anything different. I think a lot of it depends on your local regional CCHS expertise and support. If you live in a super rural area, and because you have a tracheostomy, people pay attention to you in the emergency room and immediately recognize that you have a certain level of complexity. If you are decannulated and lose that, and you are still in that rural community where people may not have as much familiarity with CCHS, that may be a barrier. It certainly has been for some of my patients. And then family individual preferences. In talking about decannulation, there must have been established feasibility of alternative support. So that means before taking out the tracheostomy, a capped trach polysomnography or sleep study done with either BiPAP and mask or with phrenic nerve pacers in place. That to me is an absolute must do. You should have ENT clearance of the upper airway. This is something that should not be done outpatient. This really is an admission, and in many places may be a PICU admission. If you need a bronchoscopy prior to decannulation, I would really recommend that that is separated, because it's general anesthesia by at least 24 hours. Otherwise, it's a bedside decannulation. Generally, kids with CCHS have very mature stomas, and so it's not something that's going to close right away. At my institution, we will oftentimes do a sleep study with an occluded stoma. So tape, tegaderm, whatever it takes to cover that up, and whatever ventilatory support done, so that we can titrate that support. At least it's not always fine tuning, but at least titrate that support so that we can make sure adequate oxygenation and ventilation are happening. Sometimes that stoma causes quite a bit of leak with positive pressure via mask. And so there's lots of discussion around that, either needing prolonged intubation or a secondary closure at the bedside. During this admission, we do lots of observation labs, clinical correlates, and even going home, there's still a lot of that. There is usually an uptick in frequency of things like sleep studies around this period of time as that stoma closes, or if surgical closure is needed, we will then need to do repeat studies just to make sure that we are still on track with our level of support. Dr. Kasi, who is at Emory, came with his colleagues and published this incredible article, which if those of you have not read, really I think is a great read. But he's proposed a nice little algorithm here for going from trach vent to mask vent with the hope of decannulation, which summarizes a lot of what I just talked about. And it's also great to know that he and I, who are at two different institutions, have fairly similar approaches going to that. But here, eligible patients who are counseled on what he's calling NIPPV or NPPV, sorry, which is non-invasive PPV. And that means practicing with a mask prior to actually undergoing this whole process, because if they can't tolerate the mask, and that also includes doing a sleep study with this capped trach and a mask on, just to establish feasibility. If they can't tolerate that, it's not quite time to do it, to decannulate yet. That really needs to be in place. You need to have that backup plan unless you are willing to risk intubation. And same for diaphragmatic pacing. Particularly with diaphragmatic pacing, you won't know until that trach is capped and diaphragm pacers are going how stable that upper airway is and what the likelihood of decannulation is. There are definitely patients out there who remain with diaphragmatic pacing as their sole form of ventilatory support while asleep, but require an open tracheostomy at nighttime in order to maintain the patency of that upper airway, so don't ever get decannulated. And there's now been several published reports of children having upper airway collapse and obstruction with attempts at tracheostomy decannulation that sometimes can be surgically addressed, but not always. So with that, in summary, just remember, optimal ventilation is the cornerstone to good health in individuals with CCHS, which is why we put so much time and effort into it. The three major modalities include trach vent, mask vent, and diaphragmatic pacing, all of which have their own pros and cons. And there's no textbook, so to speak, in terms of a recipe that matches everybody's needs. Transitioning between modalities and or decannulation involves a lot of multidisciplinary planning and should be done at a center or in consultation with a center that is well-versed in CCHS care, particularly if there is a general surgery or anesthesia component involved. And ventilatory support really needs to be tailored to best fit the individual, family, and situation in order to optimize that person's health, their outcomes, and their success later in life. Putting something like diaphragmatic pacers in somebody who we know is not going to be or is not mature enough or not responsible enough at whatever stage of life to manually put on those antennae every night, it means that somebody has to be there to do it for them. And that certainly is a different situation than somebody who is able to do that on their own in terms of maximizing that potential for success and adherence and compliance to treatment. So on that, thank you very much for your attention. I'd like to thank the Network and Foundation for allowing me and inviting me to give this talk today. And I will say goodbye from Seattle. Thank you so much.